Hello, friends. I'll be talking on this very basic topic, modes of ventilation, basic and advanced. So I thought I had done this recording. I realized the basic was not done. So I'll give a brief overview on advanced and basic. So I'm sure most of the listeners would be attending multiple workshops where you are taken through these modes of ventilation. So this is the overview, and maybe from exam perspective for advanced modes, it's good to have some salient concepts in back of your mind when you're answering this, and it's good to understand the conceptual thought process when we are dealing with advanced modes. So recently I was part of a workshop station after a long time, so it was interesting that I could take them through all these modes. So wish to thank my colleague, Dr. Pradeep, who also helped me with this content. So I'll start with the basic modes or the conventional modes. So the disclaimer is there are different nomenclature that are used with different ventilators. So it is very imperative and important that whatever ventilator you are using in your unit, it is good to get acclimatized to the nomenclature that is being used in that ventilator. So there are different names that are used for a similar sort of a science in the ventilator. So that is something that happens. And I may be talking about a lot of modes, advanced modes. So another, the TNET is that no mode has been shown to be superior over another in influencing a great clinical outcome difference between the modes. So that is also one thing that you need to keep in mind. So although we go through a lot of modes, but there is no robust data to say one mode saves lives much better than the other modes. So that's where the science is at this point of time. So I'm sure all the listeners here would be knowing assist control, and we would be talking a bit on pressure control, pressure support, and synchronized intermittent mandatory ventilation. So these are the conventional modes. So there are nomenclature for assist control. So when MACVET, so you may have heard of ventilators called servo I. Now the servo I has become MACVET, and now it all comes under the umbrella of MACVET Jetting a group, where volume control is the nomenclature used. In Dragger, they use intermittent positive pressure ventilation as the name. So these are different nomenclature, but just get acclimatized to the names that would be relevant to the ventilators you are using in your unit. So we'll just talk about assist control. So in assist control mode ventilation, there are obviously certain parameters we set. So tidal volume is set for any ventilated patient. These are some of the basic variables we set when we are connecting the patient to a ventilator, which is tidal volume. And most importantly, we set the IE ratio. In assist control, the breaths which are initiated by the ventilator are called as control breath. And the breaths that are initiated by the patient is called assist breath. And whatever breath is given, so the same tidal volume and same set rate is provided by the ventilator, and the characteristic of each breath is very similar. So that is the typical thing that happens in assist control. So the same tidal volume and the same set rate is delivered for every breath, and the characteristic of every breath remains similar in assist control. So this is just pictorially showing. If you see, there is no difference in any of the waveforms here. They all look the same. So either it is a control breath or assist breath, the morphology or the characteristic of every wave is similar. So as you see, this is the scalar, which is the flow time, and every breath looks the same. So this is the pressure time, every breath looks the same. Volume time, every breath looks the same. And in assist control, the set rate, whatever you keep as a set rate at minimum, this is very important. If the patient is breathing less than the rate that you have set, then ventilator provides additional control breath in the same tidal volume and in the same IE ratio that you would have set. But if the patient is breathing above the set rate, so you kept the set rate and patient tends to breathe above the set rate, then the ventilator does not give any additional control breaths. So this is something that you need to know. So whatever set rate, at that rate, all the control breaths are being provided by the ventilator. And in volume control, you set, as I said, for any mode that you set, tidal volume is set and inspiratory time is set. IE ratio becomes very important. So conceptually, one needs to understand what inspiratory time does, what expiratory time does. So inspiratory time, we set or we focus on inspiratory time by increasing inspiratory time. What that means is your intent is to improve oxygenation. So you increase the inspiratory time. So your thought process is the goal that you have in mind is to improve oxygenation. And longer inspiratory time improves oxygenation by increasing the mean airway pressure, causes redistribution of gases in the lung, and lowers the peak airway pressure. So these are the three reasons in which the longer inspiratory time tends to improve oxygenation. At the same time, so if you increase the inspiratory time, expiratory time comes down because the respiratory cycle time, which I'll show in subsequent, remains the same. So you increase the inspiratory time, expiratory time comes down. You shorten the inspiratory time, expiratory time increases. So there are certain conditions, as most of you would know, like a COPD. We need a prolonged expiratory time for the gases to come out, for the carbon dioxide to come out, where we shorten inspiratory time or prolong expiratory time. So shortening inspiratory time means you are prolonging the expiratory time. This is the main goal in your mind, or the intent would be to reduce over distension of alveoli or hyperinflation of the alveoli, and to reduce the risk of intrinsic PEEP because of accumulation of gases in the alveoli. So that is our understanding. So prolonging expiratory time is to reduce hyperinflation, reducing intrinsic PEEP, and reducing the hemodynamic effects on the hemodynamic deleterious hemodynamic effects, because the more hyperinflation, more intrinsic peak, there is reduced venous return to the heart, there can be more hemodynamic compromise. So this is our conceptual understanding of inspiratory. So just showing you how you set the IE ratios, inspiratory flow time, so on and so forth. So this is the volume time as you see. So if you carefully see, this first part is the inspiratory flow time. So this we would show in the exam and ask you to identify different components. So this is the inspiratory flow time. And in the volume control, there is something called pause time. So we give this as a pause time. And the pause time with inspiratory flow time is called inspiratory time. So the combination of these two is inspiratory time. And please bear in mind, in volume control, you have pause time. In pressure control, you don't have pause time because you put a high pressure and there is a sudden drop in the pressure. So there's no pause time. So this is something useful, especially in OSCEs or ventilator station, we do ask this. So there is pause time in volume time. There's no pause time in the pressure control. The combination of pause time and inspiratory flow time is the TI, which we call it inspiratory time. And expiratory time is at the end of inspiration and the beginning of the next inspiration. And the combination of these two, inspiratory time and expiratory time, is what we call as respiratory cycle time. And if you take the respiratory cycle time as 6 seconds, and normally one would keep IE ratio as 1:2. So it is equally distributed between the so 1 second for the inspiratory and 2 second is for expiratory time. And that 1 second includes the pause time and the inspiratory flow time. And the pause time is generally set as a default as 10% of the inspiratory time. And when there is tachypnea, when there's increase in the respiratory rate, the ratio becomes important. The ratio is constantly maintained. So the inspiratory ratio remains 1, pause time remains 10% of the inspiratory time, expiratory time becomes 2, it will be in the ratio of 2, but your cycle time comes down. So in case of tachypnea. So when there is a prolonged pause time, then which means you are increasing your inspiratory time, because pause time is a combination of inspiratory flow time. So which means your inspiratory time is increased and there is increase in the inspiratory flow that happens in this situation where there is absolute increase in the inspiratory time. So these are some of the correlations that happen when you are tweaking inspiratory and expiratory ratio and the pause time in volume control. As I said, in pressure control, there is no pause time. So now we'll talk volume control. As I already mentioned 2 times, that we would be setting, these are the parameters we would setting. We would set a tidal volume, and we spoke about inspiratory expiratory ratio. We set the rate, and because it's a controlled ventilation, whatever rate is set, that amount of controlled breath and assist breaths are given, and you set the PEEP. So these are the 4 basic things that you would set. And for any ventilation, one needs to din into their mind this particular understanding that your airway pressure is equal to flow into resistance plus volume divided by compliance plus P. And there are only few variables you have control on in the ventilator because you cannot set the resistance. Resistance is determined by the intrinsic nature of the lung. Compliance is determined by the intrinsic nature of the lung. So you have control, or we have control from the ventilator only on the volume and on the flow and on the PEEP. So your airway pressure is dependent on three things that we can set. So we can set the flow rate, so we can set the volume, and we can set the PEEP, but we do not have control over resistance. And the whole dynamics of ventilation revolves around optimizing our ventilatory parameters to suit the resistance or to tackle the resistance and to address the compliance issues. So the whole pathological aspects that we deal with ventilation is to deal with these two issues and sometimes minute ventilation also. And again, your whole compliance is determined by obviously this alveolar pressure, which is volume divided by compliance plus P. So that's about your volume control or assist control. So the advantages, one needs to understand what are the advantages of assist control mode or volume control mode. Is it's relatively simple to set because you don't have to break your head, just set the parameters and every breath is given the parameters that you have set. Relatively simple to set, and there is always every breath is guaranteed with minimum minute ventilation that you have set. But one of the disadvantages, I mean, you would call this as an advantage that it rests the muscles, but it could be considered as disadvantage because there's no conditioning of your respiratory muscle apparatus. This can lead to muscular atrophy very soon. So that one could look at disadvantage. So if you want to look at advantage, it is rests the muscles because it doesn't make muscles work. Disadvantage is it is not synchronized and patient may lead the ventilator. So this, when we did the station, we demonstrated as to how it leads the patient because if patient is breathing hard, then obviously assist breaths are not given to suit the tachypnea. So, and that's why one may be compelled, the person may be compelled to increase the respiratory rate. So, which means that you are chasing the needs of the patient, which ideally one should not. So, we would demonstrate this in workshop as to what happens in tachypnea, that in controlled mode, patient tends to lead the ventilator. So inappropriate trigger can increase the minute ventilation. And in the setting of low lung compliance, because the lung compliance keeps changing dynamically, and whatever set parameters you have set as tidal volume, respiratory rate, IE ratio, so if that is not customized to the patient's needs, there can be a risk of barotrauma in this controlled mode. And one needs to have increased sedation, analgesia, neuromuscular blockers, and patients should not be breathing very fast or tachypneic, or overriding the breath, which can lead to dysynchrony, so on and so forth in this. So they need more sedation, analgesia, or neuromuscular because you are not making muscles work when they are in control mode. So these are some of the disadvantages. So that's about your volume control. So we'll move to what happens in pressure controlled ventilation. So in volume control, you set the tidal volume. So these are very simple. So conventional ventilation is a single loop ventilator. So what it means is in volume control, we set the volume. Pressure becomes a dependent variable. So pressures are determined by the patient. So in pressure control, we set the pressure and volume becomes a dependent variable and it is determined by the patient. So these are all single loop. So the advanced modes of mechanical ventilation, I was telling in the workshop that one need not be very intelligent in customizing these things because the ventilator auto adjusts and make sure that you can have control over the pressure in volume control and you can have control over volume in pressure control. So that's what is the dual mode ventilation or advanced modes. That's all it is, that we have control over the pressure and volume. In conventional modes, we only set the volume, pressure is determined by the patient and we do not have control. And in volume control, we set the volume, we do not have control over the pressure and vice versa. So in dual modes or advanced modes or a closed loop ventilation, you have control over both, which we'll talk about. So in pressure control, pressure is preset and pressure is usually, when we say pressure, it is applied at the end of the ET tube. sorry, at the proximal end of the ET tube, and the IE ratio is set like any other, and there is no pause time. So as I said, in volume control, there is a pause time. Pressure control, there is no pause time. So if you look at the pressure time, flow time, and volume time in pressure control, as you see in the flow time, you saw it was a different morphology in volume control. There was a pause, and then there will be a squarish. Here, flow reaches the peak, and there is a sudden drop. So whatever pressure you set, 30 centimeter, 40 centimeter, it immediately rises and there is a sudden fall in the pressure and it reaches to zero before which your expiration is starting. So in pressure time, again, this formula is something that one needs to dig into their mind. The changes in resistance in pressure control or changes in the compliance has a bearing on the volume, which we said. And so applies in volume control. Changes in the volume has a bearing on the pressure. So here we do not have control over the pressure. So here changes in the resistance and compliance has a bearing on the volume that is delivered. So if you look at pressure control ventilation, if you shorten the inspiratory time, so this is the pressure time, this is the normal inspiratory time. So you have shortened the inspiratory time. So this has a direct bearing on the tidal volume. So the tidal volume comes down. Okay, so because it is dependent on, as I said, you need to, if your intent is to improve the oxygenation, you need to have a prolonged inspiratory time. It increases the mean airway pressure and lowers the peak inspiratory pressure. So shortening inspiratory time has a bearing on fall in the tidal volume. So the advantages of pressure control is it's relatively simple and it avoids high inspiratory pressure because it's controlled. You have preset the pressure. So pressure is controlled, but volume becomes dependent. And like in volume control, it rests the respiratory muscle and it improves oxygenation. Disadvantages, like in volume control, it's not synchronized. Inappropriate trigger leads to increased minute ventilation. Changes in lung compliance can lead to changes in the tidal volume because you do not have control over the tidal volume. We have control only on the pressure. And again, like in volume control, you need increased amounts of sedation, analgesia, and neuromuscular blocker to have a good synchrony between the patient and the ventilator because here also patient can lead the ventilator. So that is about pressure control. So conventional modes, we are just rushing through very slowly but steadily. In pressure support is a very simple thing which is used for weaning processes, especially when you want patient to breathe and you want to assist his breath with certain inspiratory pressure. So some of the nomenclatures used are inspiratory assist or assisted spontaneous breathing. So in pressure support breathing, so your expiration starts at the end of the inspiration where you set as a percentage of maximum inspiratory flow when the change to the expiration happens. In pressure support, patient determines his respiratory because in volume control, you set the respiratory rate, you set the inspiratory time and expiratory time, you set the tidal volume. But in pressure support, everything is determined by the patient. So patient determines his respiratory rate, patient determines what his inspiratory time is and what his expiration is, and he determines what his tidal volume is. So you only have to provide inspiratory assist for him to accentuate the required sort of a volumes that needs to be generated by the breath of the patient. So the advantages of pressure support is this is a weaning mode, especially when one is intending to liberate the patient from ventilator is when one would consider pressure support. Simple to set, avoid high inspiratory pressure because it is all dependent on his patient driven sort of a pressure. And usually there is a good synchrony because patient matches to the needs of his physiology and there is a synchrony between the patient and ventilator. And this is a very important mode which exercises the muscles because patient is using his muscles. You saw in controlled mode, the muscles are rested, but here muscles are made to work. So it conditions the muscles and it unloads the muscle. So disadvantages is, although this statement is wrong, I said no apnea backup. All new ventilators have apnea backup. So if you put on pressure support, if adequate tidal volumes are not generated, they go into auto backup based on the default settings that one has. All the new ventilators have apnea backup, but some of the older ventilators did not have apnea backup. And changes in lung compliance and resistance has a bearing on changes in the tidal volume. This, I'm sure every listener, when you are weaning the patient, you would have seen that if COPD, end stage COPD, they do not generate any tidal volume where the lung reserves are very poor. Or ARDS patient, when you're weaning, they may not be necessarily generating good tidal volume when they put them pressure support. So changes in lung compliance and resistance has a bearing on the type of tidal volume that patient generates. It also depends on the amount of pressure support one is giving. And generally, the pressure support range we give from 3.5 to 14.5. Although this is reference, so we would keep it at 5 to maybe 15. And pressure support less than 6 is a full criteria that that tells you that one can give a trial of extubation, provided other hemodynamic, GCS, and other parameters are good. So this is about, it's more of a weaning mode. So now very quickly we'll move to SIMV. So SIMV, although they say it's complicated, when you read any literature, they say control mode is the easy to set, pressure support is a weaning, and most literature they would say SIMV is complicated and something. But we, like I was telling in the workshop, that I use a lot of SIMV, but SIMV not in solo. It is always SIMV with pressure support, because here you see synchronized intermittent mandatory ventilation, where these are mandatory breaths and these are patients. So why we like SME is because we get the muscle to condition, because increasingly we are recognizing that diaphragm atrophy, chest muscle atrophy happens at the end of 48 hours of someone who gets intubated mechanical, which means there are multiple studies to say 48 hours post ventilation is when the muscle fibers start getting atrophied in the diaphragm as well as in the chest wall muscles. And we want to continuously condition your respiratory muscles and diaphragm muscles, and increasingly it is recognized conditioning by making them breathe may possibly help in minimizing this atrophy. That's why SIMV pressure support seems to be a good sort of a middle path, where we get them to breathe and support those breaths along with mandatory breaths. So this is a mode which I like and I use it very often. And we have seen great sort of a, I don't think it's complicated at all. But SIMV has to be used with pressure support. So what is the difference between volume controlled, pressure controlled, and SIMV? So I said in volume controlled, pressure controlled, the characteristic or morphology of every breath is same. But here, there is a difference in the morphology of the mandatory breath and the assisted breath, or the which is assisted by pressure support, and it can be flow cycled, and it all depends on whether you are giving adequate pressure support to assist the patient breath. So there is some differential, and this is something which sometimes some Puritans may frown upon, that there is a differential sort of characteristic of the breath which may lead to some deleterious effect. But there are absolutely no studies to say one mode is superior to another. So again, another picture to show the morphology of mandatory breath and assisted breath are different, which is not different in complete controlled breath. So this is the mandatory breath and this is the pressure support breath. So, and the mandatory breath can be volume controlled, can be pressure controlled, and settings in SIMV will be little more than controlled mode ventilation. Like any others, you would put an FiO2 tidal volume IE ratio, but here you put a mandatory breath, and pressure support becomes very important here. What is the type of inspiratory pressure that you are providing to optimize the assisted breath is what becomes important. That's where some of them think that it may be complicated, and the PEEP you provide, obviously. So the advantages of SIMV is, which I find it very important, is there is a good synchrony, especially when patient, and we have increasingly recognized, we do not want to deeply sedate the patients, and we want to give them sedation-free period. We want to wean patients very quickly. And I think this is the best mode where there is some sort of a synchrony that can be established between the patient ventilator with a lighter sort of a sedation. And there is a guaranteed minimum minute ventilation that you can provide with your controlled breath. Most importantly for me, it is conditioning the respiratory muscles. It is conditioning the diaphragm, which is terribly, terribly important in this day and age, where increasingly studies are showing there is deconditioning or ventilatory induced diaphragmatic dysfunction. WID is very common. Maybe it can be minimized with these sort of a conditioning ventilation. Disadvantages, you read any literature, they say it's a complicated mode. I don't believe it is complicated. So now to summarize the conventional modes, what mode would we use? So if you have a largely apneic patient, so someone has had a prolonged surgery, abdominal surgery, you want to rest the patient overnight on mechanical ventilation, and obviously we are not intending to wean and extubate. So control of mechanical ventilation becomes important. You can use assist control. Where control of peak pressure is important, you can tend to use pressure control. I won't go into nitty-gritties as to when I use pressure control, when I use volume control. Largely, we use volume control. In certain instances, we tend to use pressure control that we do work deliberate when we do workshops. And intermittent spontaneous SIMV, I would use it as a middle path where once your initial phase is over, you want to start making conditioning the muscles and want to make patient assist the breath that he's breathing. So intermittent SIMV can be used. And obviously, when you're weaning and wish to liberate the patient from ventilator, you would be thinking of using pressure support ventilation. So this is summarily the thoughts you can have in mind as to when I would use controlled mode. And maybe in a severe ARDS, initially you don't want patients to have spontaneous breath. Controlled mode is the best. And once patient is when the acute phase is settled and you are looking at sort of initiating the weaning process, maybe you can think of synchronizing the patient breath and weaning him off. So SIMV can be looked at a middle path and then later on to PSV and so on and so forth. So this is sort of a summary of the conventional modes. Now we will slowly change gears and we'll move to advanced modes of ventilation. The big question is, why do we need advanced modes? So before I talk about advanced modes, all the new trainees who are having the newer ventilators in your ICU, all the newer ventilators have advanced modes. And having advanced modes has made life easy. You don't have to worry about what sort of a volume assist you should give, what sort of a preset pressure you should give, and what tidal volume is good enough that I control the pressures, what amount of pressure I should preset to ensure that tidal volumes are achieved. You don't have to break any heads. You can set tidal volume and you can even define what should be the pressures that you should limit. And you can set the pressure and you can even define what sort of tidal volume that you should be achieving. So all these are done with advanced modes. Why we need advanced modes? Because what we realized is in conventional modes, the settings that you do initially. I said, like patient comes from OT after complicated abdominal surgery, aspiration, where you have high pressures, you have set certain modes. But after things dynamically change. So if suppose the patient is deteriorated with worsening ARDS, the settings that you have put initially may be inappropriate after 4 to 5 hours. And so is the case when patient has improved. Patient was bad, then things have improved. But what the settings you have put here, not necessarily may be optimal in a phase of improving lung or a deteriorating lung. So things are dynamically changing. So that's where you look at open versus closed ventilation. We talk about dual control ventilation is what is needed. So it's so where variables are self-adjusted and the cycle time is adjusted, limits are adjusted, and controls are adjusted. And these adjustments are not limited only to the volume, only to the pressure. These variables are sort of spread across, even they adjust the flows, they adjust the inspiratory expiratory ratios, they can adjust the volume to make sure that the goals that you are intending or set is achieved. So very broadly classifying newer modes of ventilator. So it's very important what are the different nomenclatures used with different ventilators. So we'll go very slowly with this. This is a very important. So when you use VAPS, which is volume assisted pressure support, this is a nomenclature which is specific to these ventilators, T-Bird and Bird ventilators. Volume support is specific to these brands, Siemens and Sevo 300. Adaptive support ventilation as a nomenclature is specific to Hamilton and Drager Evita. Proportional assist ventilation, this nomenclature is specific to Puritan Bennett. And mandatory minute ventilation is specific to this brand of Drager, Babylog. And airway pressure release ventilation is present in Drager and whatever AVR bi-level. And airway pressure release ventilation extended is present in Vela and Diamond series of Evita XL and Evita. So basically why I'm showing this is whatever nomenclature you are using is very specific to the ventilator brands that are available. But in essence, that's why I said at the outset, go and look at your ventilator in your ICU and see what all modes does that have. And I will show my ventilator what all modes it has. So they're all brand specific, they're all ventilator specific, and some modes are very unique and specific to certain ventilators. And BiPAP, I'm sure most listeners would know, Philips uses this word for most of their modes. BiPAP is more of Philips and Respironics. NAVA is by Servo I, Now, the buzzword is artificial intelligence. So AI incorporated ventilator, it's called Neo Ganesh. So Ganesh may be very intelligent god, so that's why they put as Neo Ganesh, and it is present in Dragger Inc. So it's present in Evita, and there is another care, AI software called Better Care, which is also incorporated in some ventilators. So the future is that you have AI incorporated ventilators, which is the next version, which is the next version of your advanced modes of ventilation, where you really don't have to do anything. You just connect the ventilator to the patient, and it automatically decides what mode the patient has to be in, what flows has to be set, what tidal volumes has to be set. They calculate resistance, compliance, and they will put it. So things are getting much more simplified now with advanced modes of ventilation. So just remember very grossly, you don't need to remember any of this, because go look at your ventilator in ICU and see what modes they have. So in exam, if they ask advanced modes, you have to just put this picture. So two broad categories. There are certain advanced modes which are unique to spontaneously breathing, and there are certain advanced modes which are hybrid. Spontaneously breathing, volume support, and proportional assist ventilation, which is a newer mode, is for spontaneously breathing. In hybrid, as I said, you have volume assured pressure support, which is VAPS. Then there is pressure regulated volume control. So this is present in most ventilators that you may be having. You may be using Macquet, you may be using Servo I or GE. They all have pressure regulated volume control. Then adaptive support ventilation, bilevel, and airway pressure release ventilation. I'm not talking about APRV because I'll do a separate video on APRV, because I'm right now writing a chapter on APRV. So airway pressure release ventilation is a very simple thing where you use two differential CPAPs, high CPAP and low CPAP, and then create a difference. And mainly, there have some trials that have happened in ARDS where it is touted to be beneficial. Mandatory minute ventilation. So, what do we understand by dual control within a breath? So, obviously, in exam, if you're writing, just put these graphs that makes understanding very easily. So, dual control, which is volume assisted pressure support, is if you have set a certain pressure and that pressure is not being achieved, so automatically for that pressure, if the tidal volume is not being achieved, so if you see there is a sudden increase in the volume to achieve the tidal volume. So suppose you are using pressure control, you have set a pressure and you are defining certain tidal volume to be met. So there is a, if that pressure is not enough to achieve the tidal volume, there is an automatic increase in the tidal volume to ensure the tidal volume goals are met. And so is the case in pressure. So if you set a volume and certain pressures are predefined, so those pressure will be assumed. And even to that effect, there can be switching from the pressure control to the volume control to achieve the set goals that you would have determined. Or it can change to the flow control. So dual control, it can happen between the breath or within the breath, it can change. So as you see here, the tidal volume is increased, and here there is increase in the pressure to achieve whatever set tidal volume. And here there is a switch from the pressure control to the volume control or to the flow control or to the flow rate. So there is change within the breath or between the breath to achieve the set targets is what happens in the dual control. And volume support, which is typically which is the nomenclature used in Siemens. So you just write these graphs, very intuitive. So here you have set a tidal volume. So with this pressure, you are not achieving the set tidal volume. You have set a some tidal volume, and the ventilator senses that to achieve this set tidal volume, there is an incremental increase in the pressure that happens automatically. There is an incremental pressure which happens by the ventilator, sensing that the set tidal volume is not being achieved. And once the set tidal volume is achieved, it does not continue to increase. That new, it sets it as a new auto set pressure and it limits this. So basically, to achieve that target, whatever pressure is needed, it automatically increments and then recognizes that as a set pressure to achieve that set tidal volume at that particular point of time. And then it keeps reassessing subsequent breaths. So that is how intelligent the newer advanced modes. So advanced modes has made simply. Otherwise, if it is a conventional mode, you have manually you have to go keep checking whether your tidal volume is set, and you have to keep turning your knobs or cranking up your pressures manually. Here, ventilator is sensing that your tidal volumes are not achieved, and it's incrementally increasing its pressure and sensing it every breath and modifying it. So that's what is all about dual modes. So this is important, pressure regulated volume control, which is present in McWet or GE ventilators, and all the newer ventilators have this pressure regulated volume control. So just pay attention. This is very important mode and very clever mode. So here there is a test breath that ventilator generates first with an inspiratory pressure of 10 centimeter water above peak. So there is the initial test breath that it delivers. And ventilator sees what is the tidal volume achieved in that pressure. Okay. And then it calculates compliance. Compliance is calculated based on the tidal volume that gets generated at some set pressure. Take an example of 10 centimeter, what tidal, and it will calculate the compliance. And based on that calculated compliance, a breath is delivered by adjusting the flow and inspiratory time. So there is an auto adjustment of flow and inspiratory time, which is determined based on the compliance to deliver the tidal volume, and the target tidal volume is delivered at the lowest peak inspiratory pressure. So this is the conceptual understanding of what happens in pressure regulated volume control. So it is calculating compliance, determining the flow rate, determining the inspiratory time, which are auto adjusted to make sure the targeted volume is generated with lowest peak inspiratory pressure. So if you are, so this is all is the conceptual understanding of PRVC, and this figure pretty much explains what happens in PRVC. So you see this very carefully. Normal compliance, it auto adjusts the pressure. This is the pressure needed to achieve the normal compliance. And then next breath, maybe after 2-3 breaths, it calculates the compliance. And if the compliance has increased, then it drops the pressure automatically. And if the compliance is decreased, the red one is decreased, it automatically increases the pressure. So with every breath, there is a assessment of compliance, and for every breath, the required pressure is generated. So there is no alternative pressures that are happening, which helps in minimizing your atelectode trauma, so on and so forth. So this is another pictorial representation. As you see, the pressure is sort of assessed with every breath to generate the required tidal volume, and it sets that pressure. So this is what happens in pressure. That's why it's called pressure regulated. It adjusts the pressure to achieve the set tidal volume. So that's about pressure regulated volume control. So very quickly, so I'm only talking about the conceptual understanding. So I won't go into the details of advantages and disadvantages. Maybe each mode I may, if the time permits, we'll do separately. So adaptive support, but understanding this much should be good enough for all these advanced modes. What about adaptive support ventilation? So in adaptive support ventilation, which is present in Hamilton and Drager Evita, understanding is optimal breathing is dependent on respiratory system mechanics. So the understanding in adaptive support is in low compliance, like ARDS, your work of breathing is reduced as a response by rapid shallow breathing, because ARDS patient, they breathe rapidly, they breathe shallow. So that is the pattern of breathing. And in airway resistance, a COPD patient, your work of breathing has to be reduced by slow deep breathing because you need to prolong your expiration. So this is your natural response to these problems. So this philosophy is adopted in adaptive support ventilation, where you determine the minute ventilation. So in adaptive support ventilation, you set the minute ventilation, and ventilator automatically plots the graph and see at what tidal volume and flow rate the optimal minute ventilation is achieved. So automatically machine is plotting the graph to determine at what tidal volume and at what flow rate is optimal minute ventilation happening. So that is on. So it adapts to the patient's needs. That's why it's called adaptive support ventilation. And the parameters one sets in adaptive support ventilation is body weight of the patient and what is the minute ventilation that we need to attain, the PEEP and the trigger. These are the things that we set. Once you set this, it automatically measures the compliance and resistance of the patient, which I showed you, plots the graph, and sees at what tidal volume and at what flow rate this optimal minute ventilation can be delivered is what is plotted by the ventilator by calculating. It is similar to like pressure regulated. In all these ventilators, compliance and resistance are factored in to determine the IE ratio, flow rate, and so on and so forth. and it optimizes IE ratio to make sure that auto PEEP is avoided, and it delivers the tidal volume and respiratory rate. So this is the philosophy of adaptive support ventilation. So the just to understand, so minute ventilation is what you said, and ventilator calculates your compliance and resistance and plots at what tidal volume and flow rate optimal minute ventilation can be delivered. So if that you understood, that's good enough in this. And this is the screenshot of how adaptive. So if you see on the screenshot of ventilator, there is a plotting of the graph at which the optimal tidal volume and flow rates can be optimized to deliver the minute ventilation. So that's about adaptive support ventilation in a very simplistic way. So very quickly we'll talk on proportional assist ventilation. So as I said, if you recall, proportional assist ventilation is like a pressure support ventilation, and this is done in spontaneously breathing patients. So as the name sounds, every breath is supported proportionate to the patient's needs. So, and this is like a pressure support where there is a synchrony between the patient and ventilator. In pressure support, what happens? You set the pressure support and you see whether the optimal tidal volumes is achieved, and then you have to again go and see if things are not optimal. Then you may have to increase the pressure support or decrease the pressure support based on the tidal volume. Here, ventilator is automatically doing by assessing every breath. So it assists. Ventilator provides assist based on the patient's effort, and there is a continuous conditioning of the muscles, and the pressure that is set by the ventilator is to overcome the elastic forces and the resistive forces and to suit the flow rate. It can be volume assist or it can be flow assist, and this changes from breath to breath, because when you set pressure support is constant for all the breaths. You put a pressure support of 12, it is constant for all the breaths. But in proportional assist, it can be 12 for one breath, it can be 10 for a second breath, it can be 8 for third breath. It all depends on what patient is generating. So as you see, the pressure support is varying constantly for every breath. This is constant. So when they ask advanced modes, just put these graphs in the exam, especially for DRNBs or DM exams. You just put these graphs, and one would know that you have conceptually understood what these modes are all about, because the pressures are changing with every breath. Okay. And it is shown in some of the physiological models that in pressure support ventilation, that the airway pressure and the total inspiratory effort pressure, there is no matching. And they are found in physiological models, there is a good matching of the airway pressure and the whole respiratory muscle effort, which is called as PMUS. There is PMUS and PAW. There is a good matching in proportional assist ventilation is what they have shown. So that's all about newer modes or advanced modes. So I have not spoken about NAVA. I have not spoken about airway pressure, release ventilation. So NAVA, I don't use it, so I don't want to talk. Airway pressure, release ventilation, maybe I'll give a detailed talk next because I'm writing a chapter on this. So now coming to AI in mechanical ventilation, just a last slide, or Neo Ganesh, these are already getting incorporated. The future is maybe 2 to 3 years from now, possibly we'll not have any ventilation workshop, because once you connect ventilators, they pretty much do everything. They determine which mode is suitable, what tidal volumes are needed, what sort of pressures are needed, and auto calculations are happening all the time. And this is already happening. So the whole concept of AI in mechanical ventilation is, despite all this science uh, we have understood there is still breath to breath dysynchrony that is happening. So AI, there is a constant assessment of how patient is responding to the every breath that is delivered by the patient. And these are some of the studies that have shown that even in a properly ventilated patient with all the science that we have understood, there are 58% of the breaths that are provided by the ventilator which are found to be ineffective. And they have found there is a huge discordance or divergence between the scalars and the low volume loops, and there can be deviation of more than 42% in most of the ventilated patients. And this has been shown in some of the studies, because this was a study where they have assessed 1024 breaths, and they've shown there is a divergence or deviation between every breath with regards to the ventilated breath and what the patient is needing, and there is this synchrony. So these are, to circumvent all this, there are AI algorithms which are incorporated, which is called as smart care or better care, where every breath is assessed and synchronization of ventilatory support is happening with every breath. And this is the future. So I'm sure now all the ventilators that will eventually come will have AI algorithm so that each and every breath is assessed by the ventilator and proportionate support is given even for controlled breath and even for spontaneous breath. And this is where we are heading. So that's the end of my talk. So this may be too heavy because there are a lot of things that I've covered in maybe last 30 minutes. So you can visit my website and rehear to this lecture. You can visit my website at www.drpradeepangappa.com. So I'll just take you through the ventilator that we have in our ICU and the modes. So this is how you see. So this is my GE ventilator where you have controlled mode, you have pressure regulated volume control, then you have SIMV VC, which means mandatory ventilation, which is volume controlled, and this is pressure controlled. Then you have bi-level, then you have bi-level volume guaranteed, and then we have volume support. So as you see, these are all the settings that we do, and and so this is SIMV-VC. And then we have airway pressure release ventilation also, which I will be talking maybe in detail in the next video. So these are all different settings that we have in our ventilators. Then obviously there are certain things which may not be there. So we don't need everything. See, we don't have adaptive support ventilation. We don't have proportional assist ventilation. So, but most of the newer ventilators will have pressure regulated volume control or SIMV with pressure guaranteed or volume guaranteed, so on and so forth, which are all dual modes. So thank you very much. So I went with this beautiful quote, and you can rehear to this because I'm sure many concepts you need to keep reading and rehearing to understand this and have a little bit of clarity. So thank you, one and all.